So I have worked as part of the Gender and Sex Development Program at Lurie Children's since it began in 2013. So we have two arms of the program. One is caring for gender diverse and transgender youth, and the other is for individuals with differences of sex development. And we think a lot about fertility preservation for both groups. And today we're going to talk about the transgender population. So the Fertility Consortium has really been a springboard to do this work and to bring together people with all of the different expertise, as you will hear all day today, because you'll hear from so many different types of specialists and people who have different, bring different types of knowledge. One of the first things we did in this field was just to have a group of people talk at one of the Fertility meetings many years ago now. And so we talked about sort of the challenges that we faced in fertility preservation for these populations. And that included, what their risk of infertility was, what the fertility preservation options were, technical requirements, and then a lot of ethical concerns and barriers to care that might be a little bit different for these groups. And this kind of gave us the foundation to start moving forward a little bit more through the Fertility Consortium. So this group poses many challenges, because you're working not only with individuals who are facing potential infertility, but also there are a lot of scientific unknowns in this field. A lot of the medical care that we provide for transgender youth is really maybe not quite at its infancy now, but I mean early childhood maybe. This has really not been happening for a long time. So there are a lot of scientific unknowns about the medical care that we provide in general, but then how that will affect fertility. There are psychosocial considerations, and we're going to talk about some of these things in more detail later. And then you're dealing with a population that is young. They may have incomplete knowledge. You might be talking about some of this with a 9-year-old. And then you're also integrating all of this with different attitudes of the youth and parents where they may or may not agree. So when you are talking to kids about fertility, you have to make sure that they actually understand basic reproduction. And so I sometimes break it down to the most basic type of approach to this, which is that you need a sperm and an egg and an oven for those two to grow, for a baby to grow. But that oven, that uterus does not have to be your own. It can be somebody else's. And sometimes you really have to start really with that much of a basic discussion. So a lot of what we're talking about at the beginning is just basic education about reproduction. But then you have to move on to talking about what is the fertility potential for any individual. So in certain things about taking care of kids in the transgender population are somewhat similar to the oncofertility population in that we expect that the testicles and ovaries are normal testicles and ovaries with potential to make eggs or sperm. Certainly we never know for any individual patient, but we assume that they all have that potential. But the issue that we face is the potential effects of various aspects of transition for individuals who are gender diverse or transgender. And it's important to note that everybody has a different view of what's right for their body. So for some people, transition may just be a social transition. They may not choose to have any medical therapy or any surgery at any point. And some people might just choose to use estrogen or testosterone and not have surgery, or some people might, so there's just all different ways to transition. And it's important to remember that you can't assume for any patient what they will be choosing or will want in the future. But the types of medical intervention that we use are shown here. And so For individuals who are gender diverse or transgender, who reach a 10 or 2 stage of puberty and are experiencing potentially gender dysphoria or a desire to prevent the secondary sexual characteristics that we can see in puberty, they may reach a 10 or 2 stage anywhere from 8 years old to 14 years old. So there's a really wide range in which at which point we may be thinking about using GnRH analogs to actually suppress puberty. And then as they get a little bit older, then in adolescence, we're talking about using gender affirming hormones. And I mean, I think the age keeps creeping younger and younger. I mean, when I started, most of the time most of the guidelines were saying not to start hormones until somebody was maybe 15 or 16. And that's certainly gotten younger and younger. And there are certainly kids as young as 12 that are starting, and they're maybe younger. But when we're talking about gender affirming hormones, that means starting estrogen or testosterone. And then for the pediatric population, most types of genital surgery are not performed until they are 18 or older. So what do these potential medical treatments, how do they impact fertility? Well, they may all affect fertility. And so we really have to kind of think about each stage of this. So in this figure, you're seeing the maturation from prenatal to through puberty, and then on to actual fertilization of oogonium and spermatogonium. And when you take a GnRH analog, that the idea is that usually and ideally, in order to suppress secondary sexual characteristics, you would start that analog around standard stage 2 or 3. And so really you're blocking the actual maturation of those eggs and sperm. So you never have mature eggs or sperm if you use GnRH analogs sort of at the most ideal early time. So you're preventing all that gamete maturation. So certainly that will affect fertility potential. So when we do that, we'll see the pausing of the gamete maturation. And then if you use gender affirming hormones, what happens if you pause the gamete maturation? So somebody's on a GnRH analog, and then what happens after that? Is there any potential for those gametes to mature at any point in the future? And what is the future fertility potential? So there are 2 interesting publications about this. And one is from 2019, in which a GnRH analog was started in a 14-year-old who was Tanner 2. And they attempted oocyte cryopreservation at age 16. So this person remained on the GnRH analog. They were given FSH and HCG. And I noted here that they monitored some of this with estradiol levels and not with transvaginal ultrasound. A lot of times, certain procedures can be more stressful for individuals in this population, in addition to the fact that they're young. Often the idea like a vaginal penetration is much more distressing to somebody who might be transgender. And so that was not done in this case. They ultimately retrieved 5 oocytes and 4 were preserved. For this patient, they did experience some vaginal bleeding and breast development with the treatment, which was distressing to them. But the breast development did regress after about 3 months. They did report a depressed mood and brief suicidal thoughts during this time when they were being treated with medications that were causing more feminizing body changes, which did not match their identity. After this was done, then testosterone was started. So the conclusion in this situation was that oocytes were harvested successfully, but there was some guarded prognosis about the potential for success in having a child, just given the fact that there were few oocytes actually that were retrieved and then preserved. But there's another paper that was just recently published that gives a little bit more optimism for this. So there's a 15-year-old who had been on a GnRH analog since the age of 10. And they discussed fertility preservation and oocyte stimulation to preserve oocytes. And so in December of 2019, they removed the hystrulin implant that was suppressing puberty. And then they had planned to start the stimulation in March of 2020, but it was delayed a bit due to COVID. In April of 2020, they started they gave Leuprolide in April and May during this delay. And then in June and July, they actually then did the ovarian stimulation and retrieval. What's different in this situation is that they had stopped pubertal suppression by this point. So they had removed the hystrulin, and then they just gave monthly Lupron for a little bit while they were waiting until they were really going to do it. But so the analog was actually stopped. So there was no suppression happening during this time. And letrozole was used, which was different than the previous case. After stimulation, 22 oocytes were preserved. So this was a much higher yield than in the previous case. And then testosterone was started afterward. The individual did have a menstrual period, and that was distressing. There were two menses, and the family had said that had it been during a normal time and not during COVID, and then in the summer, and then I guess it was ultimately some of it was in the summer, this patient probably would have stayed home because it would have been too hard for him to go to school in that situation. But, and he had some distress from the procedures. The breast tissue did increase during that time, but after being on testosterone, those changes regressed. And the patient expressed satisfaction with the results and the side effects. So this shows that you can use a GnRH analog and then do successful ovarian stimulation later. A lot of the concern has been about whether you would have so much breast development that would be too undesirable. And it seems that potentially that is not the case. So this is exciting. So then what if somebody went through puberty though? What if they were not treated with a GnRH analog during puberty and they had gone through their own ovarian or testicular puberty, and then they get to adolescence and they start taking either estrogen or testosterone? So for transgender women, they will typically be treated with any of these different medications, usually estrogen, but also they may take spironolactone, they may take other GnRH agonists. Sorry. Any of these treatments will ultimately lead to suppression of GnRH, suppression of LH and FSH, and suppression of testosterone and spermatogenesis. So there are questions about sort of short-term versus long-term effects of this. We're not going to go over this entire group of studies, but in this one review paper, they tried to look at the effects of cross-sex hormone therapy, which is kind of how the terminology was used at the time, which now we would say more gender-affirming therapy. But what happened then with sperm production and then looking at the actual Leydig cells as well. And it was really mixed. So some of these studies, and sometimes there was one patient or 5 patients or 11 patients. I mean, the only big study had like 108 patients. But really the results are very mixed. Some had severe involution of spermatogenesis and Leydig cells, and others maintained the spermatogenesis and had normal Leydig cells. And we just don't know whether what the difference is. So there are a lot of questions in terms of ongoing sperm production after treatment with estrogen. For transgender men who are treated with testosterone, there are questions about the effects of a prolonged anovulatory state. But it seems that for the most part, testosterone exposure is usually reversible. So in this study that you see on the left, there were 13 transgender men, 6 before, let's see, let me remember which one now. The transgender men who used hormone replacement therapy, so testosterone, had lower peak estradiol levels when they compared them to individuals who had not used hormone replacement therapy. But there were still 3 pregnancies that were successful. so fewer oocytes, lower estradiol, but there still was potential for successful pregnancy. And in the study that you see on the right, there were 26 transgender patients, 2/3 of whom had oocyte retrieval after hormone replacement therapy. Most of them had been on testosterone for almost 4 years. And the oocyte retrieval was higher in those that had not been treated with hormone replacement therapy than in those that had, but they still were able to, among these 26, 16 were able to bank oocytes and 7 achieved pregnancy. So it is certainly possible, but there is, but not guaranteed. So what are the other fertility preservation options? So post-pubertally, you can think about sperm or embryo banking, oocyte or embryo banking. But peri-pubertal, we can think about actual testicular or ovarian cryopreservation, just like we do for other populations. It is still considered sort of in that investigational experimental category. And I'm pretty sure that this is incomplete at this point, but there are testicular and ovarian protocols at various institutions. I know for sure that these institutions have these, that UCSF and Pittsburgh have testicular, and Pittsburgh and Lurie have ovarian. And I'm sure there are others. But it has been a little slow to gain for that option to be easy for patients to find. Individuals can forego the GnRH therapy in order to allow the in vivo germ cell maturation, but certainly then they may experience worsening gender dysphoria, which can often lead to self-harm, and then you can have permanent secondary sex characteristics that are undesirable. So for most individuals, it's really not a good option. But then, as I said, there's this hope that you can remain on GnRH analogs and then do hormone stimulation later. And this has been done for the oocytes, as we saw, but not as far as I know for sperm. But you may see a little bit of that development of secondary sex characteristics, some dysphoria, potentially depression. So it's important that anybody who's considering that knows about some of those additional potential side effects. So that kind of brings us to these psychosocial considerations that are a little different for this population. So there has been a question of sort of what is the desire for parenthood or fertility in transgender individuals. And some initial studies were conducted in adults, so transgender adults. And many of the adults expressed a desire for parenthood, whether it was biological, adoption, sperm bank, fostering. Many wanted to be a parent. And most believed that fertility preservation options should be offered, although the desire to pursue them kind of varied even among adults. And many had regret that they were not offered these options. So what do the youth say now? So it's much more variable in the youth. Their desires for parenthood vary. Their family values around biological parenthood vary. You have to think about, they're experiencing gender dysphoria. They express concerns about financial considerations and high costs. They lack awareness about a lot of fertility preservation options and really what the procedures entail. And some of them are very hesitant due to some of the invasiveness of some of the procedures. So some other factors that you have to think about. So obviously the gametes do not match their gender identity. If somebody with testicles is preserving sperm but identifies as female. And for many individuals, that is not a problem, but for some it is. Some will say that they really don't want to have, they'll say, if I identify as female, I don't want to have a baby from my sperm. Then there are these procedural complexities, so that some may trigger gender dysphoria. Even just the exams can really be very distressing for somebody that has body dysphoria. And then there's hormone stimulation with the hormones that don't match their gender identity. And then if we go on to some of the things to think about in terms of what can we do to help, what can we do to make this process work better for somebody. There are coping strategies that individuals have employed and said, you know, they focused on the reasons for undergoing the procedures. They had support from family and friends. They may use some cognitive behavioral approaches to manage some of the body dysphoria. And they also said sometimes maybe using non-gendered names for body parts can be another helpful way to make this less distressing. A number of people that are very involved in the Oncofertility Consortium have surveyed transgender and gender diverse youth. So Lena Nahata's group found that and this was quite a few years ago now, but when they went back and looked at adolescents cared for in their program, that out of 72, two who had been counseled within the medical visit pursued fertility preservation. So that's really not very many. Diane Chen is a psychologist who I work with, and in a similar evaluation, she looked at the patients that we take care of and found that 13 of 105 adolescents who were counseled within the medical visit did formal fertility preservation counseling. And of those 13, 5 chose to actually preserve gametes. And then in this other group led, and who the paper was written by Brian Wakefield, there were 66 adolescents. 52 out of the 66 were counseled within the medical visit. And of those 52, 11 received formal fertility preservation counseling. And of those 11, 3 attempted preservation, and 2 out of the 3 actually were able to preserve gametes. So you can see that despite what we see with adults saying that this is important, kids have a lot of, and young people have a lot of concerns about it, and really very few of them are pursuing it. This is one other way to look at this. So in this study of 35 trans girls, there were, 90-some% who had counseling about fertility preservation. 38% actually attempted fertility preservation, and of those, I think about 30% were actually successful. And when they said that they decided not to do fertility preservation, 17% said they didn't want children. 13% said they wanted to adopt. 17% said it was the whole body and the process to do it that they weren't interested in. And then there was this idea of sort of being a father, like using sperm when somebody identified as female. Ultimately, 9 out of the 12 of them did do preserve sperm. And the reason for the unsuccessful ones, one was unable to ejaculate, one had azoospermia, and one had oligospermia and poor sperm quality. Should I just have to plug my computer in? Hold on, I'm just gonna get my little setup changed over here. All right, well, you have to be able to see me as well, but the computer will work. I just can't have the other light on. All right, so when we're talking with youth, you have to make sure they have to understand how this all works. They have to kind of know what they think, and then they have to make a decision. And that's a lot to ask of a young person. So we need standardized counseling protocols and patient decision aids for this group. And one of my colleague that I mentioned earlier, Diane Chen, is a psychologist who received an R21 grant to actually develop such a decision aid. And this is the prototype. Some of you or people that you work with may have been part of this big international Delphi study that Diane did to determine what information really needed to be part of this. What do we really think youth need to understand about reproduction in general, about fertility preservation, and are about the potential effects of the medical interventions they may be using, and then helping them to make decisions. And so the decision aid, I have to tell you, it's so pretty just from a graphic standpoint. And it's being tested right now with youth and parents. And so the hope is that this will be available widely for anyone to use as a way to help educate and counsel these kids. And so I'm going to end there, and I will stop sharing, and I'm happy to take any questions.
Thank you so much, Dr. Finlayson.
Sure.
It's amazing. Looks like we have some questions coming in on the chat. So the first one is, for transgender males on testosterone, how are most physicians currently handling the testosterone prior to ovarian stimulation? So I would definitely appreciate your perspective on that, and we will also be talking about that in one of our cases.
I'll be honest that I don't know for sure right now. I haven't had any of my patients pursue this recently. And so typically for the few that do, we just work really closely with our reproductive endocrinologists, but I haven't done it recently. So I don't think I have any up-to-date helpful advice for you.
Which is, you know, the tricky part with a lot of these things when it's an emerging field and emerging technologies and best practices haven't been well established. But
I mean, usually there's some thought of like stopping at some point, but the how long and when do you wait? And I haven't done it recently enough to have anything new and interesting to add.
So stay tuned. We'll discuss a little bit more later in the morning. Another question, can you give an example of non-gender terms used for reproductive organs in XX individuals?
Let's see, it's a good question. So, you know, well, sometimes, for example, instead of talking about breast tissue, you can just talk about somebody's chest. And because, for example, like if somebody undergoes mammoplasty, they usually will call it chest surgery, not or top surgery. So sometimes using a little bit more generic terms there. A lot of times talking about like, well, for someone with ovaries, like instead of saying for a woman or for a like biological woman, if you just say for someone with ovaries, it kind of is a little bit more just anatomic rather than gendered. Trying to think what else has come up. Those are some of the ones that kind of quickly spring to mind.
Can I ask one, before we continue with questions, can I ask one favor where due to some last minute cancellations and joinings, we're trying to redistribute the breakout rooms. Can everyone please edit their name on their Zoom account just to include their training level and specialty? So it might be, you know, Divya Shah, REI faculty, whatever, 10th year or something like that. So if you could just do that real quick while we continue the questioning, that'll be very helpful for us as we distribute people.
And I see some things in the chat parts about other terms that people would recommend, things that somebody said that they talk about sex parts and sex cells, or instead of saying vaginal ultrasound, saying internal ultrasound. So I think all those are really good suggestions.
Mm-hmm. And Dr. Finlayson, looks like there's another question there in the chat. A few notes up, so that says that you mentioned most transgender patients undergoing a gonadectomy after 18 years of age. What are the ethical considerations for testicular or ovarian biopsy with the goal of fertility preservation at the time of initiating pubertal suppression and or gender affirming hormones?
Yeah. So a lot of this goes back to many of the things that we have faced for many conditions, which is the concerns about a child having surgery who for that may or may not be necessary surgery. So sort of the risks of the actual surgical procedure, anesthesia, any side effects, any of these other things for somebody that would not otherwise be going through surgery. So somebody that is having a testicular or ovarian biopsy or having part of the testicle or ovary removed for gonadal tissue cryopreservation who would not otherwise be having surgery. And this is, and if you're preserving prepubertal tissue, that this is still an investigational procedure. And so that is, I mean, that's what we have faced mostly at our institution as the big ethical question about whether to do this. But I think there's the additional issue now that, for example, if you see that somebody can take a GnRH agonist and then can have oocyte cryopreservation afterwards, then maybe we shouldn't be removing tissue at a younger age. Maybe we really should just be leaving it there and letting them do oocyte cryopreservation later. So I think it's partly the procedural and risks for a child for a parent making that decision for a child, and then also a lot of the scientific unknowns still in this field.
And so much of that kind of parallels, I know that wasn't the focus of today's talk, but some of the issues in individuals with differences of sex development as well, right? In terms of...
Yeah, I mean, there we face even more scientific unknowns, I think, because we often have germ cells that are not sort of typical germ cells, but yes, there are a lot of similar questions there.
All right. Well, thank you so much, Dr. Finlayson. We really appreciate your time and expertise. And thank you so much for joining us today. Like I said, hopefully, like you said, hopefully we'll get to reconvene at a future in-person fertility meeting in the spring.
Next time. All right. Nice to see you all.
Take care. All right. Why don't we take